So here are the top 10 ICU articles regarding nutrition. And without further ado, so there's an article called Enteral Nutrition in Hospitalized Adults in the New England Journal of Medicine 2025 by Gramlich. And basically, underfeeding, which is 70% of energy and protein needs during the acute ICU phase, may actually not be harmful. And basically, there's standardized nutrition pathways, but yet individualized care, which is emphasized in that article. And we're going to go through the 10 articles. So the first one is Calories 2014. It's published in the New England Journal of Medicine. It looked at 2,400 adults, enteral nutrition versus early parenteral nutrition. And the key finding there is that there was no mortality difference. You would think that maybe you should start parenteral nutrition early. This shows you that there's actually no difference between EN versus PN. Then the NutriRIA trial, NutriRIA 2 in 2018, looked at EN versus PN within 24 hours and looking at 20 to 25 kilocalories per kilogram per day. Again, no mortality difference, but the enteral nutrition group did have more GI complications. So there is no difference between EN versus PN early on. And when we say early on, we mean within 24 to 36 hours. The EDEN in 2012 looked at 1,000 adults with acute lung injury. And now we're talking about trophic enteral nutrition versus full enteral nutrition in the first 6 days. And there was no mortality difference, whether you went full on or half on. Basically, it's not even half on, it's like 10 cc's an hour. There was no mortality difference. Trophic feeding, of course, led to less GI intolerance. So the next trial to know is the PERMIT trial. 862 adults, permissive underfeeding. We're talking about 40 to 60% of the caloric goal versus full feeding, and there was no difference in 90-day mortality. The most famous one, and the one that is the most board asked question, is the EPaNIC trial in 2011, 4,640 adults. We're talking about early parenteral nutrition. That would be, let's say, the first couple of days versus late parenteral nutrition, day 8. The late parenteral nutrition actually had faster recovery and fewer infections. So, basically the recommendation is you wait at least 7 days before you start the parenteral nutrition in the medical ICU patients. PEPaNIC is the pediatric version of the trial. Early PN versus late PN. Withholding early PN reduced infections and shortened ICU stay. So it sort of corroborates what we found in the EPaNIC trial and the 2-year follow-up. It showed that the late parenteral nutrition did not impair neurocognitive outcomes. Actually might have been better if you started parenteral nutrition later. The next group of VIP articles in the nutrition ICU space are the EFFORT protein trial and the meta-analysis. So EFFORT protein trial, 1,301 ventilated adults. So should we give high protein greater than 2.2 grams per kilogram per day versus the usual? So you should know the usual is 1.2 grams per kilogram per day. There was no improvement, may harm patients with AKI or high SOFA. That was published in JAMA. So the EFFORT, and then they looked at a post hoc AKI subgroup, and the high protein had slower discharge, higher 60-day mortality. So not only are you not helping, but you're probably harming patients with AKI. And then they looked at a meta-analysis, 23 randomized controlled trials, and the higher protein group had no mortality benefit overall, and the AKI subgroup was harmful. So the overall gestalt when it comes to nutrition in the ICU is underfeeding, about 70%. Early and critical illness is likely safe. The root matters, but not for mortality. Trials like Calories and NutriRIA 2 show little or no survival benefit between EN versus PN. Be cautious with full feeding early. Early high caloric protein strategies lead to complications. We saw that in the EPaNIC trial, that you should delay parenteral nutrition, and the PEPaNIC in the kids suggest delaying parenteral nutrition as well. The protein dosing should be not very high as per the EFFORT protein trial in JAMA, and also the follow-up meta-analysis. So individualization is the key, and it shouldn't be a rigid feed maximum from day 1.